Good afternoon, everyone, and thank you for joining us for today's webinar. This is our first corporate-sponsored webinar that is being done in collaboration with Grundium. We're excited to have you all with us today for a very important discussion. Today's session will highlight Centralis's help experience with implementing remote digital cytology to address workforce shortages while also enhancing patient care and laboratory operations. My name is Shay Nore, and I will serve as the moderator for today's session. During the presentation, we encourage you to submit your questions using the Q&A feature. We will reserve time at the end of today's session for a live Q&A with our presenters. We are pleased to welcome the following presenters today. Dr. Plocharczyk is the lead pathologist and CEO of Excelsior Pathology in Ithaca, New York. She earned her Doctor of Medicine degree from Ohio State and is board certified in anatomic and clinical pathology, as well as dermatopathology and clinical informatics. Kimberly Swingle is a clinical laboratory educator with Cayuga at Centralis Health. She earned her master's degree in education from Elmira College and has been an ASCP certified medical technologist for more than 35 years. Lorraine Sanderson is a cytologist with Cayuga at Centralis Health. She earned her bachelor's degree in cytotechnology from SUNY Upstate Medical University and has more than 25 years of experience in cytology. She has a strong background in digital cytology, FNA, and ROSE. Now that introductions are complete, today's discussion is going to focus on why remote digital cytology matters in today's healthcare and laboratory environment, how Centralis Health implemented remote digital cytology, specifically focusing on their verification and validation process, as well as the practical application of technology and workflow. The current and long-term impact of remote digital cytology in their institution and how it plays a role in patient care, staffing, and their laboratory operations. What are these advancements, not only for their institution, but what does it mean for ASCT and the broader field of cytology? And at the end, we are going to conclude with a live Q&A session. At this time, I'd like to turn things over to Dr. Plocharczyk to begin today's session.
Hello, everybody. Thanks so much for having me. Just to give you some background about Centralis Health, we are a 4-hospital system in rural New York. We currently have 3 pathologists in our system and do the broad spectrum of all anatomic and clinical pathology that you'd see in a community hospital system, including GYN cytology, non-GYN cytology, surgical pathology, autopsies, and clinical laboratory medical direction. And then let's advance this. Sorry. To advance, for some reason it's not allowing me to advance. Oh, there we go. Okay. All right. So just to give you a little bit of background, this is just kind of like our broad region, and we're going to zoom into the area in the red square. So in this area in the red square, these 4 yellow stars kind of show our 4 hospitals here at the base of the Finger Lakes, and the red dots show the major population centers. Our hospitals, our 4 hospitals, are more than a couple hours away from all of the major population centers where there are tertiary care medical centers. And so in Ithaca, New York, it takes us about an hour and a half to get to Syracuse. It takes us a few hours, 2 hours to get to Rochester. It takes us almost an hour to get to the closest highway from many of our brought much of our region. So just to kind of show that we are a little bit in the middle of nowhere, and so which the rural geography I think is pretty important when we start to talk about this technology. So, one of the reasons that we got into remote pathology in general, or digital pathology in general, both for cytology and for surgical pathology, was simply out of need. There just were not enough pathologists to go around. There was a time period where we only had one pathologist in the system, and in our in our three pathologist system that's currently covering four hospitals and a broad geographic region that encompasses over 9 counties. It used to be that there were five pathologists in this system. Then there are four pathologists in the system. With retirements and difficulty in recruiting, now there are three pathologists in the system. We have a retirement coming up, and it took us a year to recruit to replace for that pathologist. These workforce shortages are not unique to us here at Centralis. This is a national phenomenon where we've seen a decrease in pathologists over the last decade or two, and an increase in the pathologist workload. And it's interesting to note my hospital system, which my current hospital, which has had two pathologists staffing it. It's been the same number of pathologists that's been staffing it for over 30 years. And over that time, we have basically had to do more and more work. And the way that you end up doing more and more work is you have to end up working at the top of your license. So when pathologists are presented with having more and more work and less people to do it, burnout is a real phenomenon that we started seeing really happening a lot with the pandemic. Um, we also have an aging workforce of pathologists. Some of the data is a little bit older that shows what our pathologist workforce, how they're aging. But in 2013, it was almost half of the pathologists were over 55, and greater than 75% were over 45. And we don't have enough residency spots and enough fresh pathologists that are replacing this aging workforce. We've only had, over about a 40-year period, an increase in the number of residency spots by around 30%, which is significantly underestimating the amount that's needed. And this graph here I have on the right just shows some of the labor data just from the job market website that most pathologists go to. And back in 2020, 2021, there were about 400 postings pretty steadily listed on this website that were open positions for pathologists. And this 2013 paper predicted the apex of retirements for pathologists in 2021. And lo and behold, the data bears that out. If you look starting in 2021, there's a sharp rise in the number of open positions for pathologists. That's been pretty steady over the years. And so basically the number of open positions between 2020 and 2022 doubled. And these positions are not filling. Additional factor that is impacting the pathologist labor market is that we're very heavily reliant on international medical graduates to fill residency positions. And immigration laws and changes, it's an unstable environment. We are currently experiencing some delays in processing of applications for H-1B visas for a lot of the pathologist workforce. And even just recently, the pathologist that we currently have at Centralis that's being recruited to replace our retiring pathologist is currently caught up in an immigration pause. And as you know, we're awaiting policy changes and things like that to advance that status. So there's some uncertainty with the pipeline of residents that are coming in about the ability to fill these positions. Um, Additionally, cytologists are experiencing very similar workforce pressures in the labor market. There is a large vacancy rate of about 13.2%, which is almost 2,000 positions of cytologists across the US. and many retirements are happening within the next 5 years. 20% of the workforce is expected to retire. And with only 140 cytologists graduating from programs every year, that number it's far below the demand, which is around 860 a year. So we're seeing a shortage, and this shortage is driven by many factors, including the training programs. A lot of training programs have closed over the past decades. And this basically creates a huge gap between what's the supply and demand. And so, one of the things that we're doing in our health system to address this problem is we are integrating. We are combining the pathology departments at multiple hospitals. Two of our four hospitals have pathology departments, and if you look, you can kind of see that if you think about pathology, it's really an assembly line, right? And each step of the assembly line requires like highly specific and licensed personnel, whether it's a pathologist, a cytologist, um, a histotechnologist. All of these people bring specialized skill sets. And when you're in a small health system where you don't have a lot of redundancy in these positions and you're relying on one or two people to perform each step along the way, the entire process can come to a halt when you lose that critical single personnel. And so, we don't have a lot of flexibility to be able to absorb big changes in our personnel. Losing one personnel might mean losing 100% or 50% of your workforce. Whereas if you're a larger institution and you lose, one or two people, it might only represent 10 or 15% of your workforce. And so you can see there has been a reduction in services in one of our hospitals over the years to basically account for this demand. We don't have any cytologists anymore at one of the hospitals. They stopped doing pap smears. They stopped doing on-site adequacy assessment. And it's just unsustainable to sustain a department this small, as small as either of our departments are. So what we're doing as a hospital system is we're combining our pathology departments, and we're centralizing to a third site that's outside of any of our hospitals because neither of our hospitals has enough room. We're kind of landlocked by the mechanicals being in the basement. And so we're consolidating our departments to a third site to be able to stabilize and achieve the scale that we need in our staffing to be able to be sustainable. And it's really important to do this centralization because it really is our only path to stability. We are covering, I have this list here of, I believe it's 9 counties that our four hospital systems cover. These are rural areas. And so there's a lot of geography. We can't stretch the people to go to all of the places that are needed to perform the work. We need to centralize and we need to capture efficiencies wherever we can. One way to capture efficiencies is to have people work at the tops of their licenses. And so basically people shouldn't be doing work that that can be done by anyone else if it's a scarce resource, right? And so in our situation, it no longer makes sense for our precious resource of the cytologists to be going to the procedures and doing the slide prep when that type of work can be done by somebody who's already at the procedure, who doesn't have that precious license, when really we need those cytologists to be screening and to be reading. And it's the same. The same thing has happened with pathologists. The pathologists no longer do things like prosect their cases or gross or type reports or make phone calls. These are all things that we've shifted that sort of work to anybody else so that we can make the most of the resource that we have. So we In this, we've decided to. We have been doing some remote on-site adequacy assessment in one of our hospitals, utilizing the cytologists at the bedside. But as we have been moving to this centralized laboratory, and we're in the process of consolidating our two departments into a centralized laboratory, where our cytologists will be coming to our centralized third site. We've been shifting our technology so that we can basically move them off site, and to be able to do the reading and everything remotely in one site. And so before offering rows, it allows us to make diagnoses, and that's affordable. But one of the problems that we experienced, especially because the one hospital in our system that offers pancreatic biopsies, um, would often experience non-diagnostic rates, and those patients would have to come back for resampling. Um, Additionally, as I mentioned before, to get to a tertiary care center that does this type of biopsy, the patients would have to travel about 2 hours to get to another hospital system to be able to do this. And there's also a wait at these other hospitals for them to do it. So it really does make sense for us to offer this service locally and regionally, because if a patient has pancreatic cancer, they don't have 3 months to wait to get a biopsy, and they don't have 3 months if their first biopsy is non-diagnostic to then get rescheduled and have another biopsy. It's really important to narrow that time between recognition that there's a lesion and diagnosis and treatment. And so, basically, after offering remote digital rows, the idea is that it balances the outcomes that we're seeking, which is we still have the same accurate diagnosis. It's not any more expensive for us to be doing this. We narrow that window between identification of the nodule and diagnosis, and probably most important in a geographic setting that's as rural as ours, and where there's so much distance between our resources, it's accessible. So being able to extend this model out to all of our hospitals in the system is our goal, and that's kind of what we're going to be talking about here. So I'm going to turn this over then to Kim Swingle to then talk about our experience with bringing pancreatic Rose FNA to one of the hospitals in our system that didn't actually have on-site adequacy assessment prior. So thank you very much.
Thank you. Yes. So how did we get from concept to competency? So bridging our clinical workflow, our lab standard, and our staff training. So we implemented a path to get this operational. So first we had a demo, and Dr. P did that for us at the sister hospital in endoscopy. Then we actually took the cart that you can see in the picture there up to the OR, to the staff, and we checked for conductivity. Did we have the right cords? Did the connections work, etc.? Where was it going to be in the procedure room? And that went really well. And the staff was so excited to get started and try this. So then we moved to staff training, which we did with some nurses. And the provider down there helped as well. And our training was, the basic: remove the needle from the syringe, make the smears, fix them in ethanol. And then we used 2 little drops of toluene blue. We cover slipped. We dried the bottom of the slide, super important. And then we placed them on the scanner. So they were able to do all that for us. So then we had a competency, because we wanted to make sure that they wouldn't, well, 1, hurt our scanner, but 2, they'd get good results. So we had competency sign off for them, and we had the cytotechnologist do that for us in the lab. And for that, we had them, make sure they could do the basics. Could they power on the scanner? Could they use the software? Could they log in and eject the slide tray? Could they load a slide? Could they allow the permission for the remote session to start? Could they change slides? And then, of course, We went over safety requirements with PPE, with goggles and gloves, and then disposing of the needle properly. So pretty comprehensive, but also simple. Then we also decided that we needed to have super users because we're going to have to sustain this training, and it would be impossible to, with the nurses overturn as well. So next slide. So how do we verify this? So our verification, is it going to do what we need it to do? And so we had the cytologist perform a verification. And did it fit? Did it form for us, fit, and function? And then our validation was the scanner able to be used for the cell adequacy checks? So per CAP, we took 60 historical cases that were already cover slipped, and then we used them, and they correlated between the glass and the digital. Next slide. So did we have any challenges? Of course, but they're very minor. So we found very early on that we had a slide that was not clean underneath and was wet. And so with any microscope and stage clips and moving around of a slide, it needs to be dry. So we realized that. So we had one of those that we had to correct. And then we also had, the slide has to be properly seated. So again, minor tweak, but once we had the slide properly on the scanner, we just hit new scan and it was able to be seen. So pretty minor problems. Next slide. Here's our data. And so pretty simple as well. So we had 2 cytotechnologists reviewing the 60 cases, and there was, they looked for live view capability. Could they navigate? Could they find their cells? Could they focus? And were they able to correlate? And as you can see, they were. Next slide. So this was, again, just kind of our summary. So we had 2 different devices we used, and the software, of course. Then were they able to do everything that they needed to do? Yes. And then our exceptions, which we just talked about, and then our final results that were that all the criteria was met. So next slide. And this is just a letter from New York State telling us that we're good to go. And if anyone knows anything about New York State, they can be pretty strict. So we were pretty excited to get this. And as well, in the letter, it said that the lab does not need to submit for review. It is offered under our general permit for our laboratory histopathology, and that our validation documentation should be maintained for our survey. So that was really awesome for us. So pretty good whenever we were able to get that from them. So next we're going to go to Lorraine, which is our cytologist who did some of that for us. And she is extremely passionate about this remote capability. And she's going to show you what it looks like from her side on the remote process.
Thank you, Kim. Thank you, Dr. Plocharczyk. I'm honored to be here, and I appreciate the opportunity, also with working with the ASCT and Todd from Grundrium. So thank you, Sam, Shay, and Josh. So on this first slide, we start by logging into the Grundium website. And once we're logged in, we're going to connect to the OCUS scanner. This will give us access to the live case and allows us to begin the remote adequacy assessment. So on this slide, you can see how remote access works. The current user sees the image on the right, and I will see the image on the left, and I will confirm my request for access, and they will allow it. And once the user grants us access, I can navigate the slide and operate the scanner. And only one person can control it at a time. That's a built-in safety feature. Others can still use the scanner to view historical cases, but only one person can drive the scan. Next slide. After I gain access, the scanner shows an overview image so I can see where the cellular material is. It takes about 7 to 10 seconds to generate this image, and we use the mouse to click where we want to view and click and drag the mouse to move the slide around or navigate within the slide. This sample for reference is a fine needle aspiration of an inguinal lymph node from a man in his 70s with a history of renal cell carcinoma. After looking at this slide grossly, we can see the cellular material is on the left end. The cytotechnologist moves to an area of interest by clicking on it, and we focus on the darker staining regions since those are most useful for adequacy assessment. Next slide. Now we're looking at a scrolled in view of this slide with the mouse scrolling forward, which magnifies it. And you can see the darker areas within the cellular material, mostly towards the center of this slide. And once we identify these darker regions, we open the live view mode. Next slide. The live view button is on the bottom right, and it opens a window that works like a digital microscope. When we start live view, the OCUS switches from slide scanning mode into digital microscope mode. Microscope mode. Okay, so the cytologist uses the autofocus and views the cells at 5x, 10x, and 20x, which you can see at the right top of this screen. We select autofocus at the bottom right of the live view window, and this puts the cells into the optimal focus. Next slide. This is a view of the 5x magnification, which just gives us a general sense of whether the sample will contribute to the adequate cellular material. Next slide. This is going to be a 10x view, which gives you a little more magnification. And now we're going to go to the 20x view. And this is where we can tell whether the cells are diagnostic for adequacy. And so we would repeat this process until we decide whether the slide is adequate on its own or if more slides are needed. At our institution, we look for at least 6 groups of 10 or more cells. And with the other areas of interest, this slide did meet adequacy, and at this point, the physician would place the rest of the sample in a cell block, and we would request a core if possible, and we would ask for 1 or 2 more passes for the cell block if this happened to be the only pass. But usually, like any procedure, you need at least 2 passes for a good cell block. So next slide. So the final step, once you've reached adequacy, is to stop the live view, and then you would simply X out of the browser to return the scanner control to the user. And if you needed to see more slides, then on the previous screen, you would select change slide, and you'd go through the process from, then you'd select new scan, and you'd go through the whole process again. And so now we will go back to Dr. Plocharczyk to discuss the current and long-term impact of remote digital cytology.
Thanks so much. So basically, we have been iteratively adopting different digital pathology technologies at Cayuga Medical Center, which is now part of Centralis, for the past 6 years. We started really in the pandemic. And so it does offer expanded support for frozen sections, for sharing cases between institutions. Right now, we have our pathologists are in different places. I'm signing out right now from a place that's about 30 minutes away from one of my colleagues and about an hour away from one of my other colleagues. And so being able to digitally scan something with a device that's small and I can keep next to my desktop, it allows me to get a faster opinion of my colleagues when we're further away. We currently also use it for tumor boards. And it's nice because when the slides are, before when we did tumor boards, we would just take pictures of, different areas of the slide. But now we can digitize the whole slide. So if the clinician asks a question in tumor board, like, is there perineural invasion? And that wasn't something we had prepared in advance, we can look at the slide and answer in real time. And also, there are additional applications that we anticipate with archiving tissue and for research that are in the future. But really, there are lots of of applications for the technology for us. And, Rose is an important application. And one of the features I wanted to mention before that when we had done Rose before, we were using technology that is basically like a live view camera on the microscope that the cytologist would manipulate the slide. But now being able to use it with something that we can manipulate the slide actually remotely, that frees the cytologist from having to be at the bedside, and that person can be replaced by somebody who doesn't have as precious a credential as the cytologist for slide preparation. These procedures can take a long time. Being in an EBIS, oftentimes the people, our technicians are there for an hour or more. And so it's nice to be able to also helps with our accessibility to be able to transfer the burden of the slide preparation and the loading of the digital technology portion of it to the operational staff of the unit where it's being performed, freeing up that cytologist to just do the reading. And that's also important as well because as the regulations have been changing, one of the things that's been happening is the read site needs to have that CLIA permit, and so we're shifting the way that we do reads in our institution. Before that ruling, I could do a read on an iPad in a dentist's office. After that ruling, I have to be in a laboratory, and that's not always feasible for a pathologist to be in a laboratory, when there are so few of us. So basically, having taking the burden of the slide preparation off of the cytologist gives them more time and ability to be able to focus on the read portion. And then so the cytologist in the laboratory reading remotely can read from those sites. So that was another reason why shifting to a technology where we could remotely manipulate the slide was important for us. I just wanted to add that. So basically the impact for us, it's been able to allow us to maintain this service that we think is important and useful, in spite of our staffing shortages and in spite of the fact that, we have multiple hospitals that are separated by broad geographic distances. And it basically, we believe it's an important technology to be able to reduce the non-diagnostic rate of specimen acquisition. We always like to be able to communicate with our clinicians in real time as they're taking the samples to get the important information to help them triage the specimen, and to reduce the need for the patient having to come back for another procedure. And again, access was so critical for us. I just see this as these market forces that are pervasive and are incumbent upon us now and in the future. Being able to adopt this kind of technology, it's not a workaround. It's not an inferior thing that we're doing. It's a shift. It's a foundational shift in the way that we're practicing medicine, and I think it's a good move for us in the future to be able to offer something that we weren't able to offer before. So thank you. I will turn it now over I believe, to our moderators.
Thank you all. You've done a great job of really highlighting how remote Rose technology is reshaping your laboratory operations, but the future of our cytology practice as well. So you've shown how remote Rose is supporting your workforce sustainability by allowing fewer cytologists and pathologists to still very efficiently cover multiple locations as well as procedure sites. This model also is helping to address the ongoing staffing shortage, any retirements, as well as the declining training pipeline that is not only affecting us as cytologists, but cytopathologists as well. as everyone has touched on, a major benefit here is the expanded patient access. These small rural hospitals, or even smaller healthcare systems themselves can now provide these advanced cytologic procedures and assessments locally, as opposed to having to refer patients to the larger tertiary care centers, which in this case are potentially many hours away. It also is part of our evolving role as cytologists. We are able to learn more skills and develop ourselves professionally while also building on our very strong diagnostic foundation that is valued not only by our cytopathologists, but clinicians as well. And this, again, frees up some time and our resource to not necessarily have to be in a procedure room all of the time. And last but not least, this technology of remote rows serves as a foundation for broader digital transformation occurring in our field and laboratory medicine in general. We know that AI-assisted cytology is becoming part of many people's workflows, as well as remote collaboration and expanded telepathology capabilities. As we wrap up today's session, there's some key takeaways that I think is important to all of us. The first, this problem that our workforce is facing is very urgent, and we know that pathologists and cytologists shortages are continuing to grow, and our current staffing models are becoming worse, and unfortunately, at some point, will be very unsustainable. And I think a lot of institutions are seeing that happen. Second, Rose is, again, very important to most of us and is critical in our day-to-day operations. But historically and even geographically, it has been very limited. It is very important to delivering high quality patient care, but traditional approaches have required trade-offs, whether this is due to speed, costs of instruments, as well as staffing and just general access to these services. We've seen how at Cayuga with Centralis Health, this remote technology has addressed many of these limitations by still enabling accurate, timely, and accessible care. All three of our presenters have also demonstrated that this implementation is very achievable, even within these very rigorous regulatory environments. CAP, and anyone familiar with New York State, has very strict requirements, and they were able to successfully do this. So kudos to you guys as serving as a great role model. And finally, our discussion today emphasizes that this technology represents only the beginning of a much broader shift towards digital pathology, including whole slide imaging, remote consultations, tumor boards, and all other future AI integrations. And it seems like Cayuga has had some experience with all of these on some level. So it's great that you guys are able to serve as a model for those who are interested in adopting these procedures. With that, we will transition to our Q&A session and address any questions that are submitted through the Q&A feature. So I encourage you all to submit your questions and our presenters will give you feedback. So the first question we have is, if the cytopathologist or cytotechnologist is reviewing slides remotely, what licensing requirements apply?
Yeah, I can take that one. And so there are some different the licensure requirement. I'm going to speak from the permits for perspective. The laboratory, the reading site where the laboratory, or the reading site where the the reading is occurring needs to be a laboratory with the permit for cytology. And so basically, we were able to achieve that through the reading location being our laboratory with the permit. And one of the things that I had mentioned earlier about that was that our prior technology that we had used for Rose, we this was before that became a rule, and that became a rule in March of this year. And so before it basically you could do it through the originating institution. The reading site did not have to be a laboratory in itself, but now it's very clear that even for Rose, the reading area has to be a laboratory. And so that became even more critical for us to be able to even make it more efficient and take the cytologist out of the procedure portion of it, since we would need them to do the reading in the laboratory. So that's one of the requirements. As far as like validation submissions to I know that a lot of people have questions about, whether it's non-FDA, FDA, things like that. And so we have been, iteratively adopting different digital pathology technologies over the past 6 years. When we first started doing these submissions, we did them as laboratory developed test submissions because they were not FDA approved. And so that's what we thought was required. And in fact, that was what was required at the time. And so we would submit our laboratory developed test, validations and protocols to the state. They would come back with approvals. And that letter that Kim showed was the last one that we submitted to New York State. And they came back with us. And I don't exactly know all the specifics behind all of this, but their guidance to us was that these validations now fall under your permit. So they're not required to be submitted as LDTs anymore, even though you're not using FDA technology. So that was our requirement. So basically, we meet our internal validation requirements. We follow the CAP, which is very specific in giving good advice and good validation protocols for validating this type of technology. So basically, if I'm understanding the question right, the license is basically the reading location requires the CLIA permit, and you follow your internal validation procedures, and that's pretty much it.
Thank you, Dr. P. And to follow up on that, somebody else had a question and said, if you validate the scanner for Rose, do you have to validate again to use it for frozen sections?
Yes, each use case requires its own validation because you're doing different things. And so yes, you validate it and you show, like that it's working. So like for a frozen section, um, it's probably different personnel that are reading it. It's also you want to make sure that you can, different types of things that you're looking at. So because it's, and you would use your most common types of cases that you're seeing. So if your frozen sections are often, lymph nodes, use those cases. Basically every use case that you're using, so that if you're using it for primary diagnosis and you use stains, immunostains or special stains, you need to include those in the validation as well. So every use case requires validation. Yeah.
Great, thank you. Our next question is, how are institutions handling HIPAA compliance for these multi-institutional collaborations involving telecytology?
That's a good question. I think that our networks in it's really not that different. I mean, we're on the phone with the people in the room and we're talking to them. We have a relationship with them because we are one institution. So it's, and we're performing patient care, so there's not really a risk there. Um, I think we follow the standard procedures that we would follow anywhere else. You know, we're trying to not have um, uh, information visible in places that it shouldn't be visible, but you know, we're reading these within a laboratory. Um, if there's a patient label, um, and actually, the way that we're doing our rows, we don't have patient identifying information on our slides as we're doing the rows because, you know, we're doing the communication. We know the patient and we're communicating on the phone. And so, because of that, there's no theoretical risk of, you know, it escaping through the ethers. So I think those are just standard HIPAA practices that you do anywhere else.
And to follow up on that, somebody else had commented that it sounds like you have to use Grundium's software slash cloud to view the slides. So how are you ensuring security with that?
Yeah, and for that, we don't have any patient identifiable information on the slide itself. There's nothing that's going through that channel that could escape. Everything that's happening there is, you know, we're communicating real time, either through our secure chats that we have in our medical record system or you know, telephone to the operators and the people in the room because, you know, it's communication back and forth anyway. We're asking, what kind of mass is this? Are you suspicious of lymphoma? You know, did it rapidly grow? All that kind of stuff. Can you take another pass? You know, can you put some in the cell block? Can you put some for flow?
Mhm.
So that's where we're communicating the patient information, and on the smear that's being shown, there's no patient information.
And then a
I'll
follow-up.
I'll comment real quickly on that, just since it's Grundium's specific question about the cloud and the security aspect. All of the images are maintained in the customer's IT environment, so no image data or patient data or anything along those lines is sent to the Grundium cloud. It's all held on the device and behind the organization's firewall.
Thank you for jumping in, Todd. Our next question is, how long does it take for the AUKUS scanner to scan a slide? We are a procedure-heavy institution with several EBIS slash navigational bronchases a day, and wondering if this would be an option to limit the time a pathologist needs to be on site.
I can tell you from a scanning perspective, that a 15 millimeter by 15 millimeter tissue section, which is sort of the industry standard for digital pathology, is about a minute at 20x and about 3 minutes or so at 40x. That, of course, varies a little bit based upon the quality of the sample. It gets longer as it's a larger sample, but it also doesn't account for the live view capability that is being discussed here. The system can do both, so that's the general time frame for scanning in a whole slide imaging capacity.
Thank you, Todd. Our next question, do you see AI replacing the role of cytotechnologists in rows through telecytology, or do you think it will only assist them, while the role of cytologists cannot be eliminated?
I can answer that one. I don't think the role of cytologists can be eliminated. I feel that, at least in my lifetime, I don't anticipate AI doing anything more than assisting, just because of what we've seen in other, you know, other visual cortex related areas. And we have seen some interesting, you know, developments in that. And, but I just feel like there's so much judgment that's captured in the human brain cortex that that is just not gonna be doing that anytime soon. Maybe 40, 50 years from now, but I think I think in our careers that's not going to be the case. I could be wrong, but
I apologize, I should have asked this question sooner, but to go back to our kind of previous discussion, somebody would like to know, are slides labeled after they are digitally scanned?
yes, they are. So after the digital, because we are using these slides for, for the permanent diagnosis as well. And so they are labeled and, at the patient bedside in the presence of the patient during the procedure. There's only one patient in this room. There's only one procedure happening. It's not as if there's anything else going on in here that this could be confused with anyone else. And so yes, they are labeled. They are sent. And so I see the other question too. Does this create a problem about the two unique patient identifiers? I absolutely not, because I feel like it's a we are putting those two identifiers on there. There's no risk in this. Like, you have to ask, what's the risk in this situation? If you had two patients in one room at one time where you're doing this, sure, there's a risk. But there's not a risk in a procedure that takes 20 or 30 minutes where that's got 6 or 8 people and everybody is, focused on that patient, that procedure. So I think that risk is low.
Great. Thank you, Dr. P. That was all of our current questions. Are there any additional questions from our participants? All wonderful questions. All right. Well, if there are no additional questions, I just want to mention, for anyone who joined late or would like to share this webinar with colleagues afterwards, a recording will be made available to you within 1 to 2 business days. And once it's available, we will have it posted on our ASCT website, and you can find that at asct.com/webinars. We appreciate you all joining us today for our first corporate sponsor in collaboration with Grundium and Cayuga at Centralis Health. Please provide us with any feedback about this webinar at info@asct.com.